So I'd like to call upon Kylie, who's going to do a presentation on young stroke. Kylie really does need no invitation. She is really, has a number of hats. She is the clinical nurse consultant or neurosciences nurse consultant and at RPA. She's been involved in the Agency for Clinical Innovation. She's now on the Health Clinical Council of New South Wales. So she brings with her quite a lot of clout, is what I'm saying. But her main claim to fame is that she's on our board. And think about that, Oshie, that she's on our board and she's on the New South Wales Health Clinical Council. So again, while she may not be speaking particularly for you, she has her ear out for us and she also has a seat at the table. Remember that. So feel free to lobby Kylie about anything you know wish to do. But she's going to talk to you about young stroke today, a topic which is very much close to her heart. Thank you, Kylie.
No worries, thanks, Michelle. All right, so as, I don't know if I'm world renowned like Michelle say, but we'll run with that for the moment.
There you are, Kylie, there you are.
So I'm going to talk about young stroke because the incidence is going up in young people. We're going to talk about the different causes because they can be different in the younger population, the impact that it has on young stroke, and then how that's changing moving forward. So I guess the first thing is the definition of young stroke changes all the time. So when I talk about my clinic, it's normally under the age of 50 that it comes through, but when we talk about a young stroke worker, we talk about under the age of 60. A lot of the numbers that I've got for you are under the age of 49. So everyone sort of has a very different version of it. And when I'm talking about young stroke, I'm actually only talking about adults. So neonates can have strokes, babies can have strokes, it can be of any age. RPA is an adult hospital, so we don't look after children, and we don't have a neuro centre that looks after kids, but I've looked after 13, so 13 is the youngest that we've had come through us. So it can happen at any age. So very excitingly, the incidence of stroke is actually going down. So over the last 20 years, I think this is, the incidence of stroke is decreasing across the general population. But unfortunately, in the younger population, it's actually going up. So in one American article that I looked at, this is 20 to 44 year of age. So it used to be 17 per 100,000 had a stroke in 1993, and that's gone up to 28 per 100,000 in 2015, I should say. So it's gone up by quite a lot there. It's similar in the Netherlands, it's gone from 14 to 17 per 100,000, but sadly an Indian study, it's gone from 4 in 100,000 to 41 per 100,000, so it's gone up by astronomical amounts. So the rates are going up and the reasons we're not quite sure of. And I guess the first big impact is money. So it does have a huge impact in terms of monetary. So one Australian study looked at it, said it's about $2 billion over 5 years it's costing. And it costs in terms of the healthcare costs, because we know what it costs to go to hospital and to look after people, rehab, that sort of thing. But it also has a huge impact on society in terms of people returning to work, carer stress, all of that sort of thing as well. So the cost is not just in healthcare dollars. So when you look at stroke risk factors, so we all know it's all the lifestyle risk factors that impact everyone, and the risks are the same no matter what age you are, but in the younger population there are a few additional ones. And the big ones that you look at there, we did speak about the vaping and things yesterday being a big issue, and it's illicit drugs. So I'm not going to jump on a bandwagon and tell you can't do any drugs, because there are certain drugs that possibly don't impact you as much as others, but there are a lot of drugs that actually do cause people to have strokes, and there are direct links between those. The oral contraceptive pill, as we discussed yesterday, it has changed. It used to be a lot worse than it was, and they've sort of reduced the amount of hormones and things that are in them, but it still is a risk factor, especially if you smoke on top of that as well. And so HRT does have similar, but they do vary it depending on what you need to take. Migraine, there are links between people having migraines and having strokes. But it does, pathophysiologically, it sort of changes the vessels and it can lead to people having strokes, and obviously a lot of young people do have migraines as well, and that can be genetic. And unfortunately, pregnancy and postpartum is also a risk as well. So when you're pregnant, you've got a lot more blood flying around the body, and it actually can cause you to become hypercoagulopathic and make you cause blood clots. But it also, during labour, people can have hemorrhages as well because of the increase in blood pressure. So we do unfortunately get a few people.
No kids?
That would be my suggestion, but apparently that's not necessarily a good thing. It's probably more keeping an eye on your blood pressure. And then I guess you've got all the traditional risk factors as well. And a lot of the problems is young people think we're invincible, as Simon was pointing out. People don't necessarily pay attention to their health, and the younger we are, the less likely we are to do it. Most young people don't have GPs. We don't get, I'll own up to this, I haven't had my blood pressure checked in years, wouldn't know what my cholesterol was. We don't check those types of things. And then when you look at a lot of those countries, especially if you look in America, people don't have access to healthcare because they can't afford it. You look in places like India and stuff, there's not necessarily the options out there for who they can go to seek help. And that's where a lot of the incidents in the lower and middle income countries are coming from, that people just don't have the access. And I mean, we're pretty lucky in Australia in terms of the access that we do have, but trying to find a GP is next to impossible in Sydney. So a lot of people just turn up when they're actually sick and they need something. So it's that primary health care that we're not necessarily paying attention to. And I guess we also lead a lot more sedentary lives than what we used to. So, as I said, so the traditional risk factors are still there. So it's still the high blood pressure, the cholesterol, the diabetes, all those sorts of things. They just seem to be starting a lot younger in people now to what they used to be. Probably changing diet and all of those sorts of things as well. The lack, as I said, the lack of primary access to primary health care. Not so much an issue in Australia, but it still is, because trying to get into anywhere is very, very difficult. And I guess that was very much highlighted during COVID as well, when people couldn't actually get access to anything. So, and you know, you had your telehealth appointments, but no one's actually checking your blood pressure, no one's doing those things that you still actually need to get done. The lack of awareness, no one thinks stroke happens in young people. So despite the fact that we talk about it all the time, people still don't realise they're having a stroke. So it's sort of one of our pet peeves. Everyone here knows fast, most people know to call an ambulance to get when that happens. But there is still a lot of people, the minute you get chest pain, people call an ambulance because they think they're dying of a heart attack. People get up and they can't move an arm, they feel funny, they can't talk, they think they'll just sleep it off, they're not sure what's happening. So I think across Australia, still less than 50% of people make it to hospital in time to be treated. And then when you add that to younger population who don't think they can have a stroke, they're less likely to get checked out as well. And it's often, the signs and symptoms can be different in younger people. They're not necessarily as specific, and they can be a lot vaguer. And a lot of young people, I find, that come through headache and things are one of the big symptoms that they do have. So they can be a bit more different to other people. Increased drug use. So there is a lot more drug use around. I think the younger population don't drink as much as what we used to when I was a bit younger, but drugs are a lot more common, and I think they're a lot more vain than what we used to be, and they don't like the calories associated with alcohol, but there's no calories in drugs, so it's a lot easier access, and it's a lot cheaper than what it used to be as well, drugs. So it is a lot bigger problem than what it used to be. The sedentary lifestyle, as I said, we don't do as much as what we used to. We're nowhere near as active as what we should be, so that's leading to a lot more problems. And pollution, that there is a lot of links now between pollution and the increasing risk in stroke, especially in those lower middle income countries. So that sort of global climate change is having an impact on this as well. So in terms of when they do have a stroke, when people are younger, and this is probably going to sound like we're not treating older people the same as what we treat younger people, but it's the risks are associated with time. So if you're 20 years old when you have a stroke, you've still sort of got 60 years to live. So the risks are magnified every year that you survive for that. Whereas if you're 70 when you have a stroke, I'm not saying that we wouldn't treat you, so please don't take it that way, the risks are less because your life expectancy isn't as great. So that's why we do a lot more investigations in young people, trying to find different causes as well. So in terms of the cardiac monitoring, so you all know when you go to a stroke unit, you get put on a heart monitor to see if you can find that someone's having a irregular heartbeat. Now we're sort of very lucky in terms of we've got extra monitoring that we can do when you go home. So when someone gets discharged, we can attach them to what we call a heart bud, which is 28 days of monitoring, and literally you wear it, it's 2 leads, and it talks to your smartphone. So So pretty much everyone gets that. If they haven't had that in hospital, we set that up when they come into clinics and we have a look. But if you're young and we still can't find anything, we do find the longer you monitor someone for, the better the chances are you find something. So for example, a friend of mine had a stroke a few years ago when she was in her 40s. We couldn't find anything on the heart, but we didn't find anything when she was in hospital. So we put in a loop recorder, which is a permanent device that goes in to actually check to see if you can find AF. And we found hers about 3.5 years after her stroke. So we do actually find it longer term. So the younger people are, the more likely we are to do the invasive monitoring to see if we can find anything. Everyone gets an echo to look to see if we can find a hole in the heart. So we look to see if we can find that, because the studies show if you're under the age of sort of 55, if you've got a PFO, we're going to close it. If you're over the age of 55, the studies haven't actually shown any benefit at this point. So anyone that's under that age, we are looking to see if you've got a hole in the heart, and we will try and close it if we can find it. And if we can't see it on an echo, if there is a high suspicion, they might do a toe, so the one that you swallow, to have a look at a different angle. We do young stroke bloods, so again, depending on the age, but generally it's anyone under the age of 60 gets young stroke bloods, and that's looking to see if you've got any clotting disorders or hematological problems, genetics and things that might actually make you more prone to clotting, and so we do all of those to see if we can find anything. And I guess the other thing that we do look for is cancer. So cancer does tend to cause stroke, especially in young people. So if someone's they've had a stroke, there's absolutely no cause. We do go down looking to see if we can find cancer that may have potentially caused it. Doesn't mean that everyone's got cancer that has it, but I think there's about a 10% chance or something that it could be related to some cancerous tumour somewhere that's causing it. And often a stroke might be the first sign of that cancer. And then we go through the same risk factor screening that we do. And I guess when Liz was talking about secondary prevention yesterday, it's a pretty big deal for a 20-year-old to all of a sudden be told that they're going to be on medications for the rest of their life. But it's the same rules apply no matter what age you are. So people are on them lifelong unless we can find an obvious cause. And then we might change it a bit later. But otherwise they're on the same blood pressure medications, cholesterol medications, and everything else that you guys all are. So prevention is pretty much the same for everyone. I will admit that half the doctors probably don't realise the stuff that I talk about in my clinics, because when I talk about most of mine is modification, I should say. So smoking, 100%. So you shouldn't be smoking. That's the one thing I will lecture. I will happily tell people to take up smoking if they vape, because I think vaping is probably a lot worse for you than what smoking is. So a lot of people will say to me, I've taken up vaping, so I've stopped smoking, but I'd rather it go the opposite way around, because the vaping, we had no idea of what it was actually doing to people in terms of the chemicals they're actually inhaling. But unfortunately, it's an extremely common thing amongst young people. Illicit drug use. It's amazing the amount of people who continue to use drugs or ask which drugs are safe to use after they've had their stroke. And it's quite sad, but I can't come up with excuses for certain drugs, so I'm not going to tell you which ones are which now, but there are some drugs that are most certainly definite nots. And it can be a hard conversation. I had a young girl the other day, she was 16, and I had to sit in front of her parents and tell her, so you can't do cocaine, and you can't do ice, and you need to try and avoid these things when you get to those ages. But so they're sort of the big things that I think impact a lot of the young strokes in terms of prevention. Same in terms of hypertension and stuff, so we're looking to have a systolic blood pressure of less than 130, so trying to get that down. If you're young and you've got hypertension, again, we look to see what causes it. So it could be lifestyle related, so it could be poor diet, sedentary lifestyle, that sort of stuff, but it could also be caused by your heart, or it could be caused by your kidneys. So if someone's got excessive hypertension that we can't find reasons for, we'll investigate to make sure their kidneys are working, we'll investigate to make sure their heart's working, to see if we can find something to actually fix to reduce their blood pressure. Cholesterol the same. We to make things easier, we aim for a total cholesterol of less than 4. So no, Liz was talking about the different types of cholesterol, but we find if you get your total cholesterol under 4, the others are aimed at what they should be. And then diabetes, it's individualised to each individual person, but regularly checking your HbA1c to make sure that that's maintained, so you've got reasonably good control. And again, diet is a huge part of it, but it's not everything in moderation. Like, it's not removing food groups, it's not getting rid of carbs, it's not doing those things. It's actually just maintaining and eating a good diet. Physical activity. So most of us don't get anywhere near as much exercise as what we're actually meant to. So WHO says it's up to 300 minutes a week of physical activity, and this is the sort of physical activity they say. So you're meant to get so many hours of the moderate and vigorous exercise. So it's that fast walking or jogging, it's cycling, it's playing tennis, it's doing those types of things. Whereas walking around slowly is good, but the younger you are, the more vigorous that activity is actually meant to be. And it's not meant to all be cardio, you're actually meant to do that weight resistant activity as well. So it doesn't necessarily have to be lifting weights and stuff, but doing squats, doing push-ups, doing those sorts of things, that you're actually using your own body weight. Diet. So as I said, it's most things in moderation. So a good friend of mine is the diabetes educator, and she will never remove foods from anyone's diet. She'll be happily, I know you said you can have a piece of birthday cake or Christmas cake. I think you can probably have it a little bit more frequently than what that is, but it's still in moderation. But it's reducing your salt, because salt is often the bad thing for your blood pressure, and looking at a Mediterranean diet, because that we do know works quite well for a lot of people. And then I guess it's what impact it has on young people. So the impact of stroke, you guys would know that better than what we do. It has a huge impact on yourself, but it also has a very big impact on everyone around you as well. And I think one of the big things that I do in my clinic is that returning to real life. Like I think if you're in hospital, you have a stroke, you sort of got all of that support around you, all of a sudden we throw you out into the real world, and we have a lot of discussions around length of stay, and you're only in hospital for 3 or 4 days on average, so it's not a long time. So most of those questions that you have, you don't necessarily think about, so you don't answer it. So when you sort of go home and have to return to the real world, that anxiety and stuff is huge, and you all of a sudden become hypervigilant about every single symptom that you have. So the minute you get pins and needles, you think you're having another stroke. The minute you're tired, all of those sorts of things, everyone all of a sudden starts thinking that something bad is going on. But it's this sort of, it's also the impact on everyone else, because especially like if someone has a wake-up stroke, all of a sudden their partners think they have to be waking someone up all the time, because what if they have a stroke and they don't get to hospital in time, or what do I do when if you have to go out and you leave someone at home by themselves? And so it's the impact that it has on everyone around you. And the problem with a lot of young strokes is they've got young children as well, and so it's the impact it has on the kids, on the rest of the family. In Sydney, it's very hard to live on one income, and so if you all of a sudden go from 2 incomes to 1 income, it's the carer stress, it's the financial stress, it's all those sorts of things that have a huge impact on everyone. There is one study actually quoted that a third of stroke survivors still remain unemployed at 8 years. So if you're 30 years old, that's a pretty big impact on everyone, like yourself, because you sort of lose your identity if you can't go back to work, or you've got to, I think people have a very hard time working out what they want to do for a job when they get older. My niece is 13 and she's in absolute panic trying to work out what job she wants. So if you have a stroke and then all of a sudden have to try and rework your career and think about what you want to do next, it's a lot of their impact on people. So the returning to work is a huge part of what I do in my clinic, trying to teach people how you actually go back to work, because a lot of people sort of, they're in hospital and they think all of a sudden, especially the ones that have a reasonably mild stroke and they don't have a lot of symptoms, you'll actually see them sitting in the hospital and they're still trying to keep work up, they're still answering emails, they're still on their phone. I'll remove phones, I'll remove laptops, because I figure at some point your body's telling you need to have a break, even if it's just for those couple of days. But a lot of people then try to force themselves to go back to normal life and push themselves a lot too quickly. So we do try and bring them back a lot quicker, so we can actually try and work through all of that with them. But I also think it's that feeling alone, because a lot of people sort of don't assume that other people have had a stroke at that age, and they don't realise that it's that common. And so it is something that I try and downplay the part that, like, whilst it might not still be the most common thing, people aren't alone. Like, I have a young stroke clinic, so I have enough people coming through that I can run a clinic for young people. So people aren't alone, and it's trying to link people up as well. Because I think support groups are amazing, but a lot of 30-year-olds don't need to want to hear that at the time. It takes a long time before they're actually willing to actually start to talk about that. And it's often sort of their second or third visit back to me before I can start getting to actually think that, yeah, it might benefit me. And then it's that, as I said, it's that anxiety about worrying it's going to happen again. we don't always find a cause for why people have had a stroke, as you guys would know. And so if there's no reason for it, what's to stop it happening again? So I was trying to talk to people and explain that whilst you have had this, we might not have found a cause. We're now treating all your risk factors. You're on the medications. You've reduced your risks. So whilst there still is a risk that it might happen again, you don't actually have to live your life every day thinking that this is what's going to happen tomorrow, because you still need to enjoy what you're doing now. And then it's that returning to work, returning to normal life. It's very hard to work out what people are going to do in terms of should they tell employers, what should they actually do. So we know you can't lose a job theoretically for having a stroke, but I mean, I had a conversation with someone this week who was made redundant 3 days before they had their stroke, and now trying to find one. He said to me, I'm just going to get my insurance to pay me out because I can't work. And I'm like, well, who said you can't work? And he said, well, the person I went for a job for told me they won't employ me. And so he disclosed it before he even went for interviews, just kept telling everyone that had a stroke, and then no one would then interview him. So it's trying to find that balance between you have to tell people that this has happened, but when do you tell people and how do you tell people? And I think it's the sort of, for me, it's people who are going back to the job they had. You've got a professional reputation, so I don't want to send someone back to work who might not be able to do the job that they were being able to do beforehand. So it's doing all of those different assessments to work out what their disabilities are they actually going to be able to go back and perform the job the same as they could, and what we can do to help that. So a lot of my patients I'll send to neuropsychology, which, whether or not you guys have tried accessing neuropsych, is very expensive and very, very long waiting lists. So I'm very lucky that apparently half of RPA is scared of me because they will give me appointments fairly quickly. So I'm very lucky that the neuropsychologist will work with us and they'll see people within sort of 4 weeks, so we can actually get that assessment done. And that way most people have got enough leave to potentially cover them for that amount of time, and then we can get the neuropsych done. And it's a peace of mind for someone that they know that there's no deficits and they know that they can go back to work. They're still thinking clearly, they're still doing that. Or it'll then tell us what areas that we do need to work on, and we can get the OTs and the rehab doctors to actually help plan a return to work pathway for them. And as I said, you're in the hospital for 3 days, you don't think about the questions that you want to ask. We might sit down and have conversations with you over and over and over again. You hear about 5% of what we're actually telling you because the anxiety is huge. So it's all of a sudden you go home, it's 3 o'clock in the morning, you're sitting by yourself, and all worst case scenarios are going through your head. So I'm sort of trying to reduce that level of anxiety, but it's also telling people that it's normal. You guys would know in terms of the anxiety, the depression is huge following stroke, but it's also a completely normal process, and you're meant to go through all of those things, and it's giving people the skills to be able to recognise what's normal, what's abnormal, and how to manage those. And then fatigue. Fatigue, as most of you will know, is a huge problem, and it is something that most people don't necessarily recognise. So when people go home, we might talk to them about fatigue, but they all sort of think, no idea what you're talking about. They're tired in hospital because we wake them up every 20 minutes by doing something in a room anyway. So you're already exhausted, and then you go home and you have to try and return to the real world. And this is where the return to work part can be very, very challenging. And so a lot of people, there's a lot of very lucky people out there in terms of their bosses who, I've got one girl who goes up 45 minutes a week every 4 weeks in terms of her returning to work for her hours, but it's trying to come up with a plan that actually suits the individual person for how you can do that. And it's very hard. The one thing I find very hard is trying to explain how long fatigue lasts, because every single person has a very different answer, and so there's sort of no big fix for me. All I can say is I've got no idea. It does get better, but some people it lasts for a very long time, others it doesn't. And so I was just trying to teach people those coping strategies. If you're a morning person, plan things in the morning, don't plan to do too much during the day, do the different little strategies that will help you, and trying to get work to actually do that. But it's also, I think it's a bit of a wake-up call for a lot of people, and it's where that work-life balance all of a sudden comes in. Because a lot of us work an awful lot of hours and don't necessarily put the time into ourselves. And so it's sort of teaching people about all that mindfulness, trying to do other things, and trying to reduce your stress levels, trying to enjoy life while you actually can, because life can be very, very short, so you sort of need to make sure you've got a reasonably good work-life balance. And whilst we might complain about younger generations, I think they actually have the work-life balance down a lot better than what we do. So I think there's something to learn from that. So as I said, it's the do you tell your employer. So I most certainly, I think that's a personal decision. It's up to everyone else what they want to do. The only time I've ever told someone to tell their employer was the other day, and she is someone who works internationally, and so when she gets sent away, they have to go with her travel insurance, and she works in a lot of war zones, so I figured that was one person who probably should tell her employee, because otherwise her health insurance won't cover her if something was to happen when she went away. But otherwise I think you guys need to work out for yourselves what you're comfortable with doing, and especially if you don't have, if we've done the neuropsych testing, we haven't found any of that, it's up to you whether to disclose it or not. But I will say I had one young patient I had there, he was a 14-year-old boy. His mum, when he went back to school, the school refused to tell anyone what had happened because they didn't want to freak anyone out that he'd had a stroke at the age of 14, and she was furious because she said she had no idea children could have a stroke, so she most certainly wanted everyone to be told what was going on. So she actually went on the TV show project to make sure everyone was well aware that young people could have a stroke. But she was hilarious. But she was like, no, we need to start telling people that it actually happens. And I think that's the hard part. I have a lot of patients who completely withdraw socially, and especially if they've got aphasia and speech deficits, they don't like to go out and do things because they think people are actually watching them. They think people are paying attention to everything they're talking about, and if they miss a word, they're all so nervous about it. Whereas I'm the first person I get up and present, I stumble over words all the time, but no one ever notices those sorts of things. But I think when it happens to you, you're just very self-conscious about it. And so I was trying to get people to go back and actually talk about things to make things normal, so people are aware that it does happen all the time. And it doesn't change who you are, it doesn't change what you do, and your friends and family aren't going to react any differently to you, but it's trying to get that back into normal habits and normal things. And then I guess it's, as we said, what do you do if you do have a deficit and you have to return to work? Because we all know people have to work, they need money, so it's often not necessarily a choice. And I've never really come up with an answer, but how do you work out what new job you do and who you go to for that advice, and how do you work out what you can physically do, what you can mentally do, those types of things after you've had a stroke. And I think it's probably something that we do really poorly at this point. I mean, Michelle might know better suggestions than what I do, but I haven't really worked out how to do that career advice stuff yet. So, as Michelle said, so when I finished my nurse practitioner, one of the things that I decided to do, we had a young patient who came through who was meant to come yesterday for the panel, and she couldn't join us. She was in her 30s when she had a stroke. She had I think it was a 3-month-old baby at the time, and she was misdiagnosed. She came in several times to ED, and she was it was a very confusing presentation because she had a concussion at the same time she had a stroke, but the symptoms were very vague. They weren't the obvious speech deficits, motor deficits, that type of thing. So she had several presentations, and she had a really rough presentation in hospital. She had a rough time in hospital, so we did a lot of talking with her to listen to her story, and one of the things she felt was she was lost when she went home. She felt that there was no one around to support her. We had our clinics where we didn't have anything that was aimed specifically at the young population, so she was the reason that we started up our young stroke clinic. So when I finished my nurse practitioner was what I decided that I wanted to do. Not that the jobs and stuff in the world don't do any of it, but I think they all come to my clinic, and given my nursing background, I think I'm much more adept at talking about emotions and doing those sorts of things that most of the consultants are. So they often come and see me, and they see the registrars, and it's a bit of a learning opportunity for them as well. So it is a safe place to talk about issues. So as I said, it's sort of a judgment-free zone. I'm happy to talk about drugs, I'm happy to talk about all those sorts of things. We can have those conversations, work out what's safe, what's not safe, and then they can talk about their fears and anxieties. I go through boxes of tissues in the clinic, there's always tears, and it's not a bad thing. I often, if people walk out that haven't cried, I think there's something wrong because I'm not sure what's going on, especially for the first visit. It's an expectation that someone has to cry. But it's a nice place to talk. I often run very over time because I underjudge how long it takes. but it's the fears and the anxieties. It's having those conversations about what the risks are afterwards, that it's talking to people in a language they understand. So I think I don't like to use a lot of numbers, so I'm not one that's going to sit there and say you've got a 17% chance of this happening again, or if we do this, it reduces your risks by that. It's just having those general conversations and trying to reduce the chances of this happening again, and talking about your risk factors, talking about what you can actually do. And it's the stupid things like returning to exercise. If we think there's something wrong with your heart, you can't go back to doing proper exercise. You've got to go back to gradually doing different things. I had one young guy who was a really big, fit, huge Islander guy, and he was big into CrossFit. And because he had heart problems, he wasn't game to go back and do it. So we knew he had AF, but so I put him on a heart bug so he could return to the gym, so he could actually see what his heart rate was doing whilst he was back at the gym. And that way it's a bit more supervised in terms of returning to it, and trying to find, we often refer people to stroke outreach, so the physios can teach people how to get back into the gym, especially if they've got some motor deficits, and they can then do it safely. So it was returning to what they were doing beforehand, but in a safe way, because often it does have to be modified. And as I said, it's the return to work is huge. So I spent a lot of time writing letters to employers about what sort of work they can go back to, what the restrictions might be, and a lot of it is around the fatigue, how much they can handle. But it's teaching those things that we don't necessarily think about. If someone sits in an office all day and they're staring at a computer, that's going to make your fatigue 1,000 times worse. So breaking it up and making sure you get outside for, even if it's 10 minutes every couple of hours, so you're walking away from the computer. One, it's good for you to get up and walk around, but it's reducing that impact of the blue light, getting people to not use phones at night time, that good sleep hygiene, setting up those good habits will try and help with that fatigue as well. And as I said, it's referring to neuropsychology, so they can try and assess. And often it's peace of mind, as I said. People aren't sure what they are capable of, and you lose all confidence. So neuropsych often then just gives you the confidence to know that you can go back and do what you need to do. And then psychology, you'll find most of us in stroke, the psychology services are terrible in hospitals. We don't have access to it at all. I don't have a psychologist attached to our stroke clinic, but I do have someone who will see someone in the short term. So if there's someone who we are really worried about, but as I'm sure you might be aware, it's about $300 or $400 a session to see a psychologist privately. So we've actually spent some time and we've found a few people who will bulk bill and do things a lot cheaper that way. Otherwise, there's a lot of letters to GPs asking for mental health care plans, so people have got access to.
I notice a social worker
psychologists. We don't have a social worker attached to us at all. No.
To your young stroke thing?
No.
Maybe that's something we should talk about.
Maybe that is. We don't even have a social worker attached to the hospital at the moment. They are very few and far between, but yes. Yeah, it would be something that would be beneficial, most certainly, yes. And so I guess what needs to happen, I think for Stroke Recovery Association, I think it's the public awareness. I think it's letting people know that people can have a stroke at any age. As I said, newborn babies have strokes all the time. It's a regularly occurring thing in premature babies, but it is at any age, anyone could have it. And as I said, the incidence is going up in young people, where it's going down in older people. So I was trying to raise that awareness. And I mean, we're not going to tell people to stop taking drugs because you might have a stroke, because we can't necessarily say all drugs cause stroke, but it's trying to look at those risk factors, especially after it's happened, to get people to stop doing it. And I think they're a different group of people with young strokes, because it impacts their life in a different way. So I was trying to think about how we're going to provide that support to people in a different way, because I think the support groups are amazing, but I also think a 30-year-old doesn't want to turn up to a support group that's full of 80-year-olds as well. So I was trying to link people into different areas, and Michelle and I have had this conversation with my few teenagers. Trying to link them in is even harder, because they're few and far between at this point, and we all only have a few that's attached, but trying to get people that they can actually sit down and talk to so they can have those conversations, because they're going back to school in a room full of people who all they know about is grandparents have had a stroke, and all of a sudden they've got to try and tell people they've had a stroke. My girl the other day, she literally was just before her Year 10 graduation from school, and her only aim was to be able to walk across the stage so she could pick up her certificate, and she actually got there there in the end, but she hasn't even told half the school what had happened to her. So it's only her close friends that know. And it's that, again, it's the fear of telling people what's actually happening and the embarrassment about it. So it's trying to work out what we can do for those really young ones at the same time. So, I don't know if I've gone very quickly, have I?
You're going okay. We've got 2 more minutes.
Oh, look at that, perfect. so as I said, so the incidence is increasing in the young people, and so it's trying to address those issues. We all think we're immortal, we all think nothing's going to happen to us when we're young, so it's trying to get people to address those issues, get people to see GPs, get them to do their annual checkups, do those sorts of stuff, and that's very much a don't do what I do, that's do what I say, because as I said, I'm probably the worst example of that. And then it's trying the recognition of stroke. So we all know fast works, but it is different in young people, and sometimes the symptoms can be very vague, and it is often, unfortunately, younger people who might have several presentations to hospital before it's actually identified. I remember I got a horrendous phone call from someone who went to a different hospital in a different area, I won't name it, and they presented 3 times, and they rang me and she said, I just need someone, I need to see someone because I'm having trouble. She was explaining she was having trouble walking, she was having trouble doing all these sorts of things, and I'm like, I don't understand how she's not in a hospital. And because it was at the height of COVID, so I literally got her to come into a car park, and I saw her in a car park, and she could hardly walk, she had terrible weakness, she had a systolic blood pressure of over 200, but because she was in her 30s, they all thought it was in her head, and no one would do anything about it. So I think it's the recognition, and healthcare is just as bad in everyone else because we don't necessarily think it's going to happen. I know my emergency department, they're actually very good anyway. They think he's having a stroke, they put out stroke calls, so we don't necessarily miss any, but they still get surprised every single time it happens. And they'll be like, oh, did you see how young that one was the other day? So I think it is something that we do need to watch out for. And that is it. So any questions?
Anybody got a question? I don't understand why you won't tell us what drugs are a problem. You know, we might be all using. Brenda, you want a question? Oh, Alan, you have one. Sorry.
Kylie, yeah, just going back to the origins of Stroke Recovery Association, it started out back in 1975 as the Stroke Talk Club.
Yeah.
So it was particularly for people who had aphasia or other problems as a result of any kind of brain injury. So at that time we did have a lot of young people, teenagers and people in their 20s and 30s who had a brain injury from a car accident. Does it make any sense to have your clinic look after those people as well?
It probably would actually, yeah. So with my other hat, I actually run a concussion clinic as well at RPA, so we do see a lot of that. We don't see a lot of the big traumas after it because they often go to the royal rehabs and the brain injury rehabs, but most definitely because they all have similar symptoms. And it's the same, I guess, with subarachnoid hemorrhage. Because whilst we talk about that as being a stroke, it's not treated by neurology in this country. It's treated by neurosurgery quite frequently, so they don't get the same follow-up. So I think, yeah, there's a lot of people we could all join together in the one group, most definitely.
And we had somebody on the phones the other day who just had that same issue, that they'd had some sort of a concussion and then a stroke came about 2 or 3 days later, but they went into a neuroscience ward, they didn't go into the stroke ward, and as a result they missed out on a lot of information they needed to link in with the services they needed. Yeah. It's really hard. Brenda?
Sorry, didn't realise you were beside me. When you were talking about investigations, and obviously, you know, it's hard to sort of cover everything. When I had my stroke, a long time ago, I think a few years after I had it, I had an angiogram, and they put forward the fact that I potentially had fibromuscular dysplasia, and it was a decade, pretty much a decade later, before they actually nailed that, like I dissected my internal carotid artery. They knew what I'd done, but they didn't know why I'd done it. And so it was only really a decade later we went, you know, it was FMD. Yeah. And I know that fibromuscular dysplasia is not a common one, but there, you know, in my realm, I actually know a number of people who had FMD strokes. So is that something that's kind of looked into?
No, 100%. It is one of the risk factors that we look for.
Yeah,
so especially if someone's had a dissection, we'll often do an angio if they're young to see if we can find causes for it, and we'll do blood suicides as well.
Okay.
Yeah.
Okay. So it's now the
It's a recognised risk factor now.
Okay.
Most certainly, yes.
Because it was not that.
Yeah, no, it most certainly is now one of the official risk factors, that we screen for.
Kylie, I had my stroke when I was 2 weeks shy of 55, and one of the biggest issues I found, I told my employer, because I was at work when I had my stroke, and I tried to go back to work, and I found fatigue was my biggest issue because I have to drive an hour and a quarter each way to go to work. And I tried that, and it just completely wrecked me by the third day. In fact, going home took me about 3 hours to drive home, with stopping every 20 minutes and literally falling asleep. But when I went back to work, he said to me, "What's the plan?" I said, "Exactly what's been communicated by the hospital and to my manager, and it's a graduated return to work." And then he swung around and said, "Well, we're not in the business of a rehabilitation business." And I actually had photos on my phone of text conversations, but it became quite apparent by the second day I tried to be at work. And I was only trying to do a couple of hours a day, and it became quite evident that they weren't going to sack me, but they really didn't want me back either. So for me, I had 2 adult children, but my wife and I were empty nesters, but my role in life has always been the breadwinner, and I was sitting there in hospital trying to work out how long I could survive without depleting any resources, financial resources I had. So most of what you've raised here resonates very strongly with somebody like me. And I enjoy being amongst these people. However, I am quite aware there are very few younger people in these sort of groups. We'll catch up later.
No, that is very true, and I think it's the support groups I think are amazing. I mean, I turn up here all the time, I obviously agree with them, but it's getting people to be willing to actually do that, and a lot of people it takes a long time before they want to do that and join
My
those.
point is, even though an employer can't sack you because of
They
that,
can make it very hard.
they make it very difficult.
Yeah.
And all it was just a modification of my role within the work, but they weren't prepared to
Yeah.
be flexible
Yeah.
to do it.
And I'm not sure if it's getting better because I think we see that less and less now, but it most certainly is. I mean, I had two people from local policemen from the same area that had strokes within a very short space of time, and their work actually then went and did a huge thing around work-life balance, all those sorts of things to try and reduce their risk factors, because both of these had very bad strokes, but both ended up going back to work in sort of different capacities. But it is, I think the employers are trying to get a lot better. I've had the same conversation at work because we've had several people who've had stroke calls whilst they're at work, and trying to work out what we can actually do to make it easier. Yeah, that most definitely is an issue.
There are also organisations that can advocate and work with people in regard to that as well. And the other thing is that there are legal implications too for an employer who will not accept a graduated return to work. And I know, I'm well aware that can be got around, and I'm well aware that people make life very difficult for people who had a stroke. But I think one of the things that's part of the advocacy role is sometimes we have to name and shame as well, because it's not going to change unless we do stand up for what our rights are, and stand up sometimes loudly and quite strongly. And that lady who certainly went on the Courage project to say it does happen to young stroke. I think it takes a lot of courage sometimes to do that, but it also means it's out there for everybody else. And in your situation, you can make that decision for yourself. I'm not sure I'd be prepared to make that on behalf of my child as she did, because it does have implications for their life journey and whether or not they're going to get a job. because, you know, stroke is still one of those things that people see somehow or other limit your intelligence, and that's not always the case, in fact. It's not always the case at all. So we have to continually argue against that as well.
But I just went with the thing of, well, if that's how they really feel about my contribution to work, I think that's better off not being there.
Yeah.
And just working on, as the doctor said, bonus time, sit outside, enjoy the sunshine, listen to the birds, and drink cups of tea. Yeah.
But the other implication of that too is your lifetime earnings. Yeah. And don't forget, never untick that box in your superannuation that says, you know, for permanent and for temporary and permanent disability, that needs to be ticked. I don't care how old your kids are, you make sure they tick that so that it's covered. It might cost them another $2 a week, but it's worth it. And remember, we have a RAFME who'll work with us to assist us to get that come through. It makes TPD. Sorry, it's TPD.
Total and permanent disability.
Total and permanent disability.
You have to check.
You check. Everybody knows.
It's definitely
Because I remember when Lachlan came home and he said, with his superannuation, he said, I don't need that. I said, yes, you do. You know, it's those things, and it's about knowing what you're signing, and it's about knowing what you're going to get, because that will be the difference between whether or not you have a good quality of life as well. If you do choose to not work in the workplace and have sit in the sunshine, which there is a lot of in our platform, I might add.
Yes.
So, and one more question. I'll allow one more question. Okay, I'll go with you. Sorry, go ahead.
Can you hear me?
No, go on over. Because we are, you know, it's amazing how we talk too much, isn't it? As you, Kylie.
This is a little bit off track. Quite a while back after my mum had the stroke, I went to Dr. Google, shame on me, to find out if there was a hereditary factor with stroke. And when I did do that, it was a mixed bag of all sorts of answers. Is there any research being done in regards to that, and are you aware if there is a hereditary factor?
Genetics definitely play a part in stroke, 100%, because cholesterol and things is very much genetic related, just as much as lifestyle related. And there are, like, aneurysms and things can be hereditary as well. So most certainly there is genetic links involved. Yeah, but having one family member does not make it a genetic problem. It needs to be multiple and direct family. Yeah.
Thank you.
I was going to say something like that too.
All right, Julie, you get the last one. Okay, sorry.
Mine's actually a comment on the lady that went onto the project. I have a niece who has a daughter who has very badly affected with Tourette's. She is now a psychologist working with Tourette's children. But when she was at school, when they found out, the mother went to the school and asked to address the children in her class so that they knew that the child had the problem. And apparently the kids accepted that, the problem, and accepted her as she was. Unless if you put it all up, you can't go anywhere.
That's exactly right. Exactly right. Yeah.
Okay.
You've been very persistent.
You referred to the support you get when you leave and everything. I found, and I think other people have found too, when I saw my GP after having a stroke, I had no business. I lost all of that, so it really devastated me, and I was sad. My GP said you've got depression, and he put me on depression tablets for 6 months, I think it was. I said, I'm not depressed. I said, I've had a life-changing event. It's made me very, very sad. There's a difference between depression and sadness, and yet they do it all the time. They just what you say, you're depressed. They need to be educated.
No, so we most certainly wouldn't treat someone for depression in the first 6 months, because you're 100% correct. You're meant to feel upset. You're meant to feel upset by it and depressed. So it's not a depression unless it impacts your life. So if you lose your motivation to eat, to sleep, to do rehab and things, then we would potentially treat it, but otherwise we would let you go through it, and hence we'll refer you to psychology rather than medications. Yeah.
And there is mixed treatments available, because one hospital may react the way Kylie does, but another one it will be automatic, putting on antidepressants.
Yeah.
And there are some studies that indicate that antidepressants can assist cognitive development as well.